Our next speaker will be known to many of you. It's Professor Jeffrey Lipman. So he's one of the major chief investigators on CRE reduce, and he's a professor of medicine at University of Queensland and has adjunct professorial appointments at QUT and University of Sydney. Very importantly, he's the director of the Burns Trauma and Critical Care Research Centre, from which the idea for CRE reduce was born. And he's been researching this area for a long time. I won't say quite how long, I'm sure he will tell you, but he's been a significant inspiration on my career, and certainly without him we wouldn't be here today talking about this really important issue. So he's going to talk to us now about CRE reduce in the context of patients in the intensive care unit.
Thank you for those kind words, Jason. So I'm going to give you the intensive care perspective of antibiotic dosing, and antibiotic dosing, as far as I'm concerned, is one of many causes of resistance and one of the drivers of resistance. It's certainly not the only driver, and certainly there are other important causes, but focusing on intensive care, I'll try and show you why we're doing what we're doing and in what group we're doing it. So when a drug company designs or gets the idea of a compound, or a scientist gets the idea of a compound, they look at it and try and develop the compound, and then often put it into a mouse model or a small animal model, and largely look at toxicity in that mouse model. They then will try and extrapolate dosing into phase 1 studies in often medical students that need money, but human volunteers, and really look at toxicity, because the human volunteers haven't got an infection, and they're really looking at toxicity in phase 1 models. Then the drug company releases it at a certain dose with a package insert, either before they do it in sick patients, but release the compound. And that package insert often goes into guidelines, and certainly when you look up a dose, how do you give a dose of drug X in intensive care unit, you'll see give Y milligrams. Now the problem with intensive care is that the antibiotic regimes are derived from non-critically ill volunteers whose hemodynamic system is normal, as is their liver and kidney blood flow. And they certainly, from an infection point of view, don't have the leaky capillaries and the problems we have in ICU. And if you see a sick patient in ICU, not only will they have probably 10 different drips, but they often initially will swell up because of the capillary leak that a severe infection causes. So the dosing of the package insert, which is an important phase in the development of the antibiotic, doesn't cover intensive care. The company is scared, quite rightly so, to put their drug into an area of patient care that is going to have deaths, whether it's drug-related or not. It's not good for the drug or for anybody else. So a patient like this with a whole lot of drips that need a whole lot of fluids and that need resuscitation have different dosing requirements, and from this diagram here you can see why, have different dosing requirements to the standard ward patient or the standard that was given to the medical student. And the main differences in intensive care unit relate to the swelling of the acute infection, the increased volume of distribution of the drugs, the increased clearances largely of the drugs with increased cardiac output, increased hepatic and renal blood flows. Often in intensive care, and I haven't got time to talk about it, one of the acute phase responses is a low serum protein. You come in, the albumin is low, therefore protein binding is different, and there's a lot of free fraction around, and free fraction goes through the kidneys. And then when you really, a lot of the patients that come in may have renal dysfunction, and a lot of them need renal replacement therapy and other techniques. And again then, clearance automatically changes from that package insert. And we've done therapeutic drug monitoring studies, and one of our studies where we thought we knew how to dose, we still needed to change the dose after measuring, in 75% of the patients. And that's after we thought we knew what we were doing. And there are two common and big problems in intensive care, where if I give you a drug, your peak serum level will be like that. But what happens because of the increased volume of distribution in intensive care, the green area occurs, and therefore if you need a peak serum level or something, you can see it's automatically different in the intensive care unit. And then on top of that, the next big problem is clearances in the intensive care unit. And there's a picture of increased clearances, the blue area against the increased clearances of the intensive care type patient. And this is what happens in intensive care. You have to volume resuscitate the patients, and they just swell up. And the antibiotic often goes into those swollen places, and that's the cause of often the increased volume of distribution of the initial dosing. And Jason and I conceptually looked at this cartoon many years ago, where in the septic patients, there's a lot of patients that we come into intensive care that have renal dysfunction, have a lot of surgery, that may be the older age group with organ dysfunction, and there's no question that if you don't change the dose, you can give too high a dose. There's a group of patients in ICU that would be similar to that medical student type pharmacokinetics. But there's another group in intensive care that I've been concentrating on for many years that have these leaky capillary, increased volume of distribution, and low plasma concentrations if you give the same dose, compounded often by an increased cardiac output and increased clearances. And this increased clearance took us a long while to work out. It took me 10 or 15 years to conceptualize it, and then Andrew Udi's in the audience somewhere, did a PhD, and has probably got 40 or 50 publications on clearances in the intensive care unit, and it's a very important concept. So we initially looked at two compounds in intensive care, and they were being excreted quickly, but they were different. And it took me a while to realize that if you looked at drug clearance on that axis and creatinine clearance on that axis, you and I, as we sit here, have creatinine clearances of about 100. And when your creatinine clearance is low, your drug clearance is low, and we know we have to decrease the dose. But more importantly, there's a group of ICU patients that have much higher creatinine clearances than you and I, largely from this inflammatory response, increased cardiac output, and increased renal and hepatic blood flow. And with this increased creatinine clearance, we showed an increased drug clearance. And if you increase your drug clearance for the same dose, you're going to be underdosing. So we, with Andrew, coined the term augmented renal clearance with creatinine clearances arbitrarily just greater than 130. Now, why is that important? Well, if you look at the literature, and we reviewed it almost 10 years ago, no matter what compound you put against the bacteria, no matter what antibiotic, the bacteria will become resistant over time, particularly if the doses are low. And we saw that with the quinolones initially, which is easy to prove, but if you look at the other antibiotic classes, underexposure allows the clever bugs, survival of the fittest, Darwinian principle, the bugs will become resistant. So if you allow a low concentration, no matter what antibiotic you use, the clever little bugs will develop resistance. And this is some work that we're doing with Monash, which is the type of work we're going to be doing here at PACE, looking at, over time, right, the killing or the log colony-forming units on that axis of various doses of antibiotics. So to explain this kill characteristic curve, that's the control group of bacteria that grow over time. And as you add antibiotics to it, so you'll kill off the antibiotics. And often we look at static MIC, or we look at a static kill curve. But this allows us to look over time the regrowth of organisms. And these are various dosing regimes simulated from humans into the bacteria. As you increase the dose, or if it's a low dose, there'll be regrowth. And as you increase the dose, so you prevent the regrowth of organisms over time. And this is relatively new technology because we could only do it over maybe 6 hours or 12 hours. Here you can see over days, organisms will regrow unless you give them significantly higher doses. Right, so there's regrowth with underdosing. But more important as well, the organisms that regrow are at a higher MIC. In other words, those organisms that do regrow are resistant to the treating antibiotic. And this, to me, is a fundamental to what we're going to be doing. Not only are we going to try and dose properly, we're going to try for patient cure, we're going to try and dose to prevent the development of resistance over time. That's the clearance, that's the dosing. I don't want to go into it too much, but 40% of our patients in intensive care come in with low serum albumins, and that changes the way we give drugs that are particularly protein-bound, but a lot of the drugs. That just compounds and creates more problems with the intensive care unit. And then, on top of this diagram here, we think we're clever and we're actually treating patients well. We put them on extracorporeal circuits to keep them alive, and it's becoming more and more common. And not only are they renal replacement circuits, but they're ECMO circuits, and there may be other circuits. And then the package insert doesn't help us at all. So of no consequence to how you dose with extracorporeal circuits. And there's no, you can theoretically look at equations, but they don't work. You've got to test how to give the antibiotics in those patient populations. So often what we do in intensive care unit, what we've done is we bastardized the renal unit technology. In the renal unit, you get one kidney, one type of artificial kidney on a patient, which is standardized often across the world. The blood flows of dialysis are the same. The way you give a 4-hour dose in a renal failure patient often is the same in South Brisbane, North Brisbane, in the rest of the world. So you can then create guidelines from that, easy. But what we've done in ICU is we've taken those circuits and said, well, we don't want intermittent dialysis in the intensive care unit. It's too difficult and it interferes with our hemodynamics. We're going to use continuous renal replacement therapy in ICU. The problem is that we do it differently to the south side of the river. South side does it differently to Prince Charles, does it differently to Europe, to Belgium, etc. Everybody runs their circuits differently. And therefore, the dosing from the textbook and a review article, unless you've measured it, is extrapolation at its worst. And we know that you can get rid of electrolytes and water with this dialysis. So you put a semi-permeable membrane across it, you will take off electrolytes and water. So what we do is we say we want to get the creatinine or the urea down, but we don't look at how we get the drugs out or how the drugs are cleared. And this is a big problem in intensive care units. So we're busy looking at worldwide practices and getting the concentrations of antibiotics sent here, so we will then be able to predict from how Ghent intensive care unit set up their machine with their dose to how Nimes in France set up their machine, to how Hong Kong sets up their machine. Because I know when I worked in Hong Kong, it's different to what I do here. And it's different to the south side. And that's partly because there are a whole lot of different continuous renal replacement techniques. There's continuous veno-venous hemodialysis, or there's hemofiltration. There's also shorter bursts of dialysis. So until we sort all of this out, we are bound to give either too high or too low, or just arbitrarily, if we're lucky, the correct dose. So just to summarize, the intensive care patients, I think, are one of the reasons why we get the intensive care as the center for resistance formation of antibiotics. If you look at the international literature, it's burns units and intensive care. I think this compounds the problem. It may not be the only problem, but because of the increased volume of distribution, clearances, and the renal replacement therapies, we aren't dosing properly in the intensive care. And we've been working on it, and we've redefined most of the doses in a lot of categories, and we're still continuing. So this is just a summary of a review article we've published, and you can see how the intensive care infrastructure changes what we're doing all the time, and therefore how we should be dosing. And it's this group here that we are underdosing on, those two groups. And as I try to show you, underdosing not only doesn't give decent patient outcomes, it allows the organisms to become resistant for the next infection. And it's this group that we're going to be concentrating on in REDUCE. Thank you for your time and attention.